Good morning, everyone, and welcome. Thank you for being here today. I'm Dr. Asim Haseen, and I'm excited to present to you on a critical topic, acute fulminant liver failure. Today, we'll explore what this condition is, its causes, clinical features, and how we can manage it effectively. I look forward to sharing insights and engaging with you throughout this presentation. Let's take a closer look at this case. We have a 38-year-old woman who was previously healthy, presenting 5 days after developing jaundice. She's now showing signs of confusion and asterixis, which suggests hepatic encephalopathy. Her labs reveal a very high ALT of 2,800 IUL, an INR of 1.8, and a bilirubin of 220 micromoles per liter. Notably, she has no prior history of liver disease. This scenario highlights a rapid onset of severe liver dysfunction in a young individual without previous liver problems. The key here is the combination of recent jaundice, altered mental status, and lab findings showing significant liver injury and coagulopathy. When we consider the options, we need to think about conditions that can cause acute liver failure, meaning sudden, severe liver dysfunction in someone without pre-existing liver disease. So, which diagnosis fits best? It's most consistent with acute liver failure, or ALF, because of the rapid progression, the severity of liver enzyme elevation, and the neurological symptoms. This case exemplifies the importance of recognizing acute liver failure early, as it requires prompt management and often urgent evaluation for transplantation. It also emphasizes how acute liver failure can occur suddenly in otherwise healthy individuals, which is a crucial concept in understanding liver disease progression. The correct answer here is B now. Let's discuss what ALF actually means. ALF stands for acute liver failure, which is characterized by new-onset hepatic dysfunction in a patient who doesn't have any chronic liver disease. Key features include coagulopathy, specifically an INR of 1.5 or higher, and any degree of encephalopathy. In this case, the patient has severe transaminitis, which indicates significant liver cell injury, along with an INR of 1.5 or more, and signs of encephalopathy. These findings meet the criteria for ALF. Understanding these components is crucial because they help us identify acute liver failure early, so we can initiate appropriate management promptly. This ties into the overall theme of recognizing different hepatic conditions and their clinical implications. Let's look at this scenario carefully. We have a 29-year-old patient presenting with acute liver failure of unknown cause. The labs show significantly elevated liver enzymes and an INR of 2.3, which indicates impaired liver function and coagulopathy. Paracetamol ingestion is a possibility, but it's not certain. Now, when it comes to management, timing is crucial. If we suspect paracetamol overdose, early administration of N-acetylcysteine, or NAC, is vital because it can prevent or limit liver damage. But in this case, since the ingestion is uncertain, we need to act promptly based on clinical suspicion and lab findings. The key point here is that in cases of suspected acetaminophen poisoning, especially with elevated INR and liver enzymes, the best course of action is to start IV NAC immediately. This is because NAC is most effective when given early, ideally before significant liver injury develops. Waiting for confirmatory paracetamol levels might delay treatment, and delay can be detrimental. The other options, like waiting for levels, giving only glucagon or vitamin K, or starting broad-spectrum antibiotics, are not the most appropriate initial steps in this scenario. So, the most appropriate immediate pharmacological management here is to start IV NAC immediately to maximize the chance of revering or limiting liver injury. The correct answer here is D now, moving to the key point. When we suspect acute liver failure, or ALF, the priority is to start IV NAC immediately. It doesn't matter if we don't yet know the paracetamol level or the exact time of ingestion. The evidence clearly shows that early administration of NAC improves outcomes, whether the ALF is caused by paracetamol or other factors. So, the most important thing is not to delay treatment while waiting for test results. Starting NAC promptly can make a significant difference in patient recovery, emphasizing the urgency and importance of early intervention in these cases. All right, let's look at this scenario. We have a 50-year-old man with acute liver failure who's become drowsy, and his bedside glucose is quite low at 1.9 mmol/L. He's showing signs of encephalopathy and cannot tolerate oral intake, so we need to act quickly. The key here is recognizing that this is a hypoglycemic emergency. The priority is to rapidly correct his low blood sugar to prevent further brain impairment. Now, when choosing the best immediate management, we want an option that provides quick and effective glucose delivery. Option A suggests giving 50 ml of 50% dextrose intravenously and starting a continuous infusion. This is a good choice for rapid correction, especially in someone who's encephalopathic and unable to take oral glucose. Option B, giving oral glucose gel, might be helpful in less severe cases or when the patient can tolerate it. But in this situation, it's not ideal because he's not tolerating oral intake and is already showing signs of neuroglycopenia. Option C, just observing and rechecking in 30 minutes, is definitely not appropriate here. We need to act immediately because of his altered mental state and dangerously low glucose. Option D, a single IM glucagon injection, can help in some hypoglycemia cases, especially if IV access is difficult. But in this context, IV dextrose provides a faster and more reliable correction. Lastly, option E suggests giving a 10% dextrose bolus, then stopping all fluids, which isn't optimal because a higher concentration like 50% dextrose provides a more rapid correction needed here. So, considering all this, the most appropriate immediate management is giving that rapid IV bolus of 50% dextrose and then maintaining with a continuous infusion. It's crucial to act fast in these hypoglycemic states, especially with altered consciousness. The correct answer here is A now. Let's talk through why. Hypoglycemia is actually quite common in acute liver failure, or ALF, and it can be really dangerous if not addressed promptly. When you suspect hypoglycemia, the first step is to treat immediately with an IV dextrose bolus. This quickly raises blood sugar levels and stabilizes the patient. After that, it's important to start continuous IV dextrose, like D10, until the patient can tolerate sustained enteral intake. This helps maintain stable glucose levels over time. And remember, frequent rechecking of blood glucose is crucial, because we want to avoid both hypoglycemia and hyperglycemia. This approach ties back to our overall theme of managing complications in ALF effectively. Rapid recognition and treatment of hypoglycemia can really make a difference in patient outcomes. Let's look at this clinical scenario carefully. We have a 45-year-old patient with acute liver failure, evidenced by an INR of 3, which indicates significant coagulopathy. Now, this patient has suddenly deteriorated. GCS has dropped from 10 to 6, and they exhibit hypertension, bradycardia, and asymmetric pupils. These signs are highly suggestive of increased intracranial pressure, possibly progressing towards cerebral herniation. When managing such a critical situation, the key is to act swiftly and appropriately. The options here include giving large volume IV fluids and waiting, urgent measures to lower intracranial pressure, immediate lumbar puncture, oral mannitol at home doses, or beginning dialysis only. The most appropriate immediate step is to undertake urgent measures to reduce intracranial pressure. This involves strategies like intubation with the head elevated, administering hypertonic saline or mannitol, and avoiding hypoxia or hypercapnia, which can worsen brain swelling. It's crucial to recognize that lumbar puncture isn't indicated here because it can worsen herniation risk in increased intracranial pressure, especially with signs of brain herniation. Giving oral mannitol at home doses isn't suitable in this acute, life-threatening scenario. Starting dialysis alone wouldn't address the immediate cerebral crisis. So the best immediate management is option B, urgent measures for raised intracranial pressure. since timely intervention can be life-saving and potentially prevent irreversible brain damage. The correct answer here is B now. Let's talk through why. ALF, or acute lymphoblastic fever, predisposes patients to cerebral edema and herniation, which are serious complications. So, in emergency situations, our main goal is to protect the brain and airway. That means securing the airway with intubation using neuroprotective techniques to avoid further injury. Next, positioning the patient with the head elevated about 30 degrees helps reduce intracranial pressure. We also want to administer hypertonic saline or IV mannitol. They're effective in controlling ICP. It's important to avoid swings between hypocapnia and hypercapnia because these can worsen intracranial pressure issues. Additionally, correcting any electrolyte imbalances is crucial, as disturbances can exacerbate brain swelling. One key point to remember is that lumbar puncture, or LP, is contraindicated in this scenario because it could precipitate herniation. So, overall, quick recognition and careful management are essential to prevent deterioration in these patients. Let's look at this case. A 32-year-old patient with paracetamol-related acute liver failure who is still acidotic despite resuscitation, with an arterial pH of 7.25. Their creatinine is elevated at 320 micromoles per liter, and they have grade III encephalopathy, with an INR of 7. This scenario indicates severe liver failure with multi-organ involvement, and the persistent acidosis suggests ongoing deterioration. The key here is recognizing that this patient is entering a critical phase. Now, considering the options, the most appropriate next step is B. Refer urgently for a liver transplant assessment, especially since they meet the King's College criteria. These criteria help us identify patients who are unlikely to recover without transplantation. Other options like supportive care alone or waiting for spontaneous recovery aren't suitable here because of the severity. Starting high-dose vitamin K won't address the underlying liver failure or coagulopathy at this stage. Giving only FFP and reassessing in 48 hours also isn't enough, given the patient's ongoing deterioration. So, in summary, when faced with a patient like this, the priority is to urgently evaluate for a transplant to improve their chances of survival. The correct answer here is B now. Let's clarify why. The King's College criteria for paracetamol-induced acute liver failure, or ALF, are quite specific. They include an arterial pH less than 7.3 after resuscitation, which indicates significant acidosis and poor perfusion. Additionally, there's the triad of a markedly elevated INR, typically over 6.5, along with increased creatinine levels and advanced encephalopathy. These factors together point to a very poor prognosis and signal the urgent need for transplant assessment. The key takeaway is that we should not delay referral when these signs are present, because early intervention can be life-saving. This discussion ties into our overall theme of recognizing severe liver failure early and acting promptly to improve patient outcomes. Now let's look at the definition of ALF, which is something you must know. ALF, or acute liver failure, is characterized by new hepatic dysfunction in a patient who doesn't have any prior chronic liver disease. This means the liver suddenly starts to fail, and there are specific features to look for. One key point is coagulopathy, which is indicated by an INR of 1.5 or higher. This shows the blood's ability to clot is impaired. Additionally, the patient may develop any form of encephalopathy, which is a brain dysfunction caused by liver failure. Importantly, these signs and symptoms occur over days to weeks, highlighting how rapid and severe this condition can be. Understanding this definition helps us recognize ALF early and differentiate it from chronic liver issues, guiding prompt and appropriate management. Let's go through the immediate priorities when managing acute or fulminant liver failure. First, airway protection is critical, especially if the patient's GCS is 8 or less, or if they show signs of rapid encephalopathy. Ensuring the airway is secure can be life-saving. Next, addressing hypoglycemia promptly is essential. Administer an IV bolus of glucose and follow up with a continuous infusion to keep blood sugar stable. This helps prevent further neurological deterioration. In cases where ALF is suspected, starting IV N-acetylcysteine promptly is important, and you should do this without waiting for lab levels. Early NAC can improve outcomes and is a key part of supportive care. When it comes to blood products, avoid giving fresh frozen plasma indiscriminately. Only administer blood products if there's active bleeding or before procedures to reduce bleeding risks, but avoid unnecessary transfusions. Finally, close monitoring and supportive care are vital. Keep an eye on blood glucose, electrolytes, INR, lactate levels, renal function, and hemodynamics. Managing these parameters carefully helps stabilize the patient and guides further treatment decisions. These steps form the core of immediate management in fulminant liver failure, and acting swiftly on these priorities can significantly impact patient outcomes. Cerebral edema is a key killer in these situations, so it's crucial to watch for signs of worsening neurological status. Keep an eye on the Glasgow Coma Scale, or GCS, because a decline there can indicate increasing brain swelling. Also, be alert for Cushing's triad, which includes hypertension, bradycardia, and irregular respirations. These are classic signs that the brain is under significant pressure. Pupillary changes can also be a warning sign of herniation or increased intracranial pressure. For emergency treatment, the goal is to stabilize the patient quickly. Elevate the head of the bed to about 30 degrees to facilitate venous drainage from the brain. If airway compromise is present, intubate with a neuroprotective strategy in mind. This means avoiding hyperventilation or anything that could worsen brain ischemia. Use hypertonic saline or mannitol to reduce intracranial pressure, but always remember to avoid hypotension and hypercapnia, as both can worsen brain injury. If available, neurosurgical or intracranial pressure support should be considered promptly. The key is early recognition and intervention to prevent irreversible damage. Now, shifting focus to acute or fulminant liver failure, this is another critical condition we need to understand. It's characterized by rapid deterioration of liver function, often leading to coagulopathy and encephalopathy. This can happen very quickly, so close monitoring and early intervention are essential. Both these conditions, cerebral edema and acute liver failure, highlight the importance of timely recognition and management in critical care. Let's now focus on some of the key etiologies we need to consider urgently when assessing liver failure. The most common cause in the UK is paracetamol, so it's essential to always check the level of paracetamol in the blood and treat promptly with N-acetylcysteine or NAC. This can be life-saving if administered early. Beyond that, we should also think about viral causes, particularly herpes simplex virus, which can lead to severe hepatitis. Ischemic injury, drug reactions, especially from hepatotoxic medications, and Wilson's disease, which tends to affect younger individuals, are also important considerations. Pregnancy-related liver issues can sometimes cause similar presentations, so keep that in mind when evaluating pregnant patients. Now, when we talk about acute or fulminant liver failure, this is a rapid deterioration of liver function with widespread consequences. Recognizing these causes early is crucial because management strategies differ significantly. The key here is a high index of suspicion and prompt intervention to prevent further deterioration. Overall, understanding these etiologies helps us act quickly and potentially save lives by initiating the appropriate treatment without delay. Let's talk about prognosis and the importance of transplant referral in cases of acute or fulminant liver failure. It's crucial to use the King's College criteria to determine early transplant eligibility. These criteria help us decide when a patient needs urgent intervention, whether the cause is paracetamol overdose or other factors. Remember, do not delay discussions about transplant. Early referral can significantly improve survival rates. The sooner we identify patients who might need a transplant, the better their chances of recovery. In the context of acute or fulminant liver failure, acting quickly is essential. This condition can deteriorate rapidly, so timely decision-making is vital. Overall, early recognition and prompt referral are key components in managing these critically ill patients effectively. Let's go over some critical ICU pearls for managing acute liver failure. First, start NAC therapy even if the cause isn't entirely clear. The benefits can be significant, and early intervention can really make a difference. Next, it's essential to correct glucose levels aggressively because hypoglycemia is quite common in these patients and can be lethal if not addressed promptly. Also, be cautious with FFP transfusions. Don't give FFP routinely just because the INR is elevated unless there's active bleeding or if an invasive procedure is planned. Overuse can lead to complications without benefit. Another key point is early transplant referral. Don't wait and see if the patient stabilizes. Rapid recognition and timely transfer are vital because transplant can be life-saving. When it comes to cerebral edema, remember that management differs from routine raised intracranial pressure. Fluid balance becomes especially crucial here. Maintaining optimal hydration without overloading is essential to prevent worsening edema. Overall, in acute fulminant liver failure, these principles help optimize outcomes and ensure we're providing the best possible care in these critical situations. Thank you for your attention. I really appreciate you taking the time to go through this presentation. I hope the key points we've discussed today have been clear and useful for your understanding. Remember, the main takeaway is how these concepts can be applied practically to make a real difference. If you have any questions later, please don't hesitate to reach out. Once again, thank you so much for being part of this session.